The PROpel study and the MAGNITUDE study both presented results at GU ASCO this year. They're both looking at combining abiraterone with a PARP inhibitor in first-line CRPC setting. So the PROpel study combined abiraterone and olaparib, and MAGNITUDE combined abiraterone and niraparib. So a lot of discussion when these were presented was around what's the difference between these studies, especially in terms of those with HRR mutation negative, since the PROpel study was positive for this group, but a magnitude was negative. And to be honest, I still don't know the answer for that. It's not really clear why that is. Some of the discussion was around how the testing was done. Patients were tested by tissue or by cell-free DNA, and it could be that if they were tested by cell-free DNA, there was too low of circulating tumor DNA in there to detect mutations, and so maybe some patients who were positive were thought to be mutation negative. Are these practice-changing studies? But that's probably the biggest question. And as of right now, I think it is still sort of in the eye of the beholder. I think the data for those with BRCA1 and 2 mutations is pretty compelling. Um, so in magnitude, as I said, the hazard ratio I think was 0.53. The hazard ratio for those with HRR mutations in PROpel also was pretty strong, was pretty low. I forget the exact number. But we don't know what percent of those patients were BRCA1 and 2 positive versus other mutations. They looked at about 14 mutations in total. I think a lot of people are especially interested in what the overall survival data will look like. Radiographic progression-free survival was the primary endpoint, but of course, they'll be continuing to follow the overall survival data. Both trials had pretty similar looking curves with some separation um, pretty late. Early on, the two curves looked very similar for overall survival, and then they started to separate after a couple of years. But the data is pretty immature for both studies. I think a lot of people are also interested in knowing what subsequent therapies people received. Did people go on to receive a PARP inhibitor, especially those that harbor a mutation? So, in other words, is this a study of early versus late PARP inhibitor, or is it a study of PARP inhibitor versus no PARP inhibitor? And I think those things will be quite interesting. In the end, my guess is that a lot of, or at least some people will find that this is the radiographic progression-free survival data is compelling enough that for those with BRCA1 or 2 mutations, they may consider using abiraterone in combination with a PARP inhibitor, especially though for those patients that are fit and could tolerate the added toxicity of dual agents. But I think most people will probably hold out until we see the overall survival data and more details of the studies coming out for those who don't harbor a homologous recombination mutation. Complicating the question of how to implement these studies is that for the most part, these studies were done for patients who had progressed on ADT alone or ADT with prior docetaxel, and not for patients who were on an AR pathway inhibitor in the metastatic hormone-sensitive setting. AR pathway inhibitors or therapy intensification is probably still underutilized for a large majority of patients in the general population. Um, but in general, we know that there is a strong overall survival benefit. And so most patients should be getting some kind of therapy intensification, especially if they are fit, relatively fit, and can handle the added toxicity for an AR pathway inhibitor or chemotherapy. In the end, I think before this changes practice for large numbers of patients, I think probably most people are still waiting for additional data. But it's very encouraging seeing added benefit and seeing the benefit of PARP inhibitors moving to an earlier time point. And so obviously these were impactful studies and generated a lot of discussion and interest at the meeting.